Bronchiolitis. Bronchiolitis is inflammation of the bronchioles. Epidemiology. It primarily affects children less than 2 years of age. Peak incidence of occurrence is 2 to 6 months of age. It is common during winter months. Etiology. Most common causative agent is respiratory syncytial virus, a paramyxovirus. Less common, parainfluenza virus, influenza virus, adenovirus, rhinovirus, coronavirus, metapneumovirus. Transmission is through air droplets or contact surfaces. Risk factors for severe RSV infection in children. Age less than 6 months is the single most important risk factor. Most RSV hospitalizations are below 6 months, especially infants less than 3 months of age. Comorbidities. Preterm birth, especially if associated with chronic lung disease of prematurity. Congenital heart disease. Immunocompromised state. Neuromuscular disorders that affect the ability to clear airway secretions, for example spinal muscular atrophy. Environmental factors, childcare attendance, exposure to tobacco smoke, in utero or after delivery. Clinical features of bronchiolitis. Initially, upper respiratory tract infection symptoms, for example copious clear rhinorrhea, low-grade fever, cough, followed by lower respiratory tract infection symptoms, crackles, wheezes, and a rhonchi on auscultation. Severe illness. Respiratory distress usually occurs in children less than 1 year of age. Signs of respiratory distress are tachypnea or apnea, prolonged expiration, nasal flaring, intercostal retractions, cyanosis. Bronchiolitis is often associated with poor feeding. Infants with nasal congestion might be taking breath from mouth. Feeding will further restrict their ability to breathe. Crackles, wheeze, rhonchi, retractions or drawing in or pulling in of chest skin on inspiration. It is sign of respiratory distress. This is normal breathing. These are intercostal retractions or recessions. These are subcostal retractions or recessions. In a patient with respiratory distress, retractions or recessions can be found at these points: suprasternal, substernal, supraclavicular, subcostal, and intercostal. Diagnosis of bronchiolitis. Bronchiolitis is a clinical diagnosis based on the patient's age, less than 2 years, and the presence of classic clinical features of bronchiolitis. Arterial blood gases. Arterial blood gases are indicated for worsening severe disease and are impending respiratory failure, may show hypoxemia and/or carbon dioxide retention. Respiratory viral panel. It contains PCR of respiratory syncytial virus and other viruses such as influenza or rhinovirus. It is not routinely done. It may be used for epidemiological studies. Studies to exclude differential diagnosis, not routinely recommended. Blood culture, a urine analysis and urine culture, CBC, and basic metabolic panel. Chest X-ray in bronchiolitis is done if there is severe disease or if there is diagnostic uncertainty or suspected complications, for example pneumothorax or pneumonia. Potential findings on chest X-ray: it may be normal, it may have non-specific findings, for example peribronchial thickening, hyperinflation of the lungs, interstitial infiltrates, atelectasis. Superimposed complications, for example, pneumonia. X-ray chest, PA view of a child with respiratory syncytial virus. Extensive peribronchial thickening has caused the hilar and perihilar regions to appear prominent. Additionally, the lung volumes are large as a result of air trapping. Signs of air trapping are hyperinflation of the lung. On chest X-ray are ribs go further apart, there is greater inter-ribs distance, flattened hemidiaphragm, visualization of more than 6 anterior or 10 posterior ribs above the hemidiaphragm, 1, 2, 3, 4, 5, 6 anterior ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 posterior ribs. This is the same X-ray chest PA view of a child with respiratory syncytial virus. Extensive peribronchial thickening, examples indicated by green circles, has caused the hilar and perihilar regions to appear prominent. Peribronchial thickening Peribronchial thickening can be seen on X-ray in the form of circles. Circles have inner lucent or dark region, while the boundary of circle is opacified. Additionally, the lung volumes are large as a result of air trapping. One of the radiographic features suggestive of hyperinflation is the visualization of more than 6 anterior or 10 posterior ribs above the hemidiaphragm, indicated by numbers. Anterior ribs 1, 2, 3, 4, 5, 6. Bilateral hyperinflation and right lung consolidation. X-ray chest APV of a child with viral bronchiolitis and focal pneumonia. Bilateral perihilar peribronchial thickening is accompanied by hyperinflation with diaphragmatic depression. In the right lung, a superimposed area of consolidation from pneumonia is associated with atelectasis and ipsilateral mediastinal shift. Consolidation, perihilar peribronchial thickening, trachea shifted towards right side, ipsilateral mediastinal shift, diaphragmatic depression due to hyperinflation. Bilateral hyperinflation and right lung consolidation. X-ray chest AP view of a child with viral bronchiolitis and focal pneumonia. Bilateral perihilar peribronchial thickening. Examples of bronchi indicated by green lines is accompanied by hyperinflation with diaphragmatic depression indicated by white lines and arrow. In the right lung, a superimposed area of consolidation from pneumonia, red overlay, is associated with atelectasis and ipsilateral mediastinal shift indicated by black arrow. Atelectasis is the collapse of alveoli. When alveoli collapse, there will be loss of pressure on mediastinum due to which ipsilateral mediastinal shift occurs. Black outline trachea, white dashed line, physiological position of left hemidiaphragm. Outpatient treatment of bronchiolitis. Educate caregivers on signs of deterioration such as dehydration, poor feeding, lethargy or irritation, new fever, and/or signs of respiratory distress, and the need to seek immediate medical attention if present. How and when to provide nasal suction. Nasal saline drops followed by external bulb suction can improve symptoms in young children. Nasal suction is recommended if nasal secretions are excessive and before meals. Excessive suction should be avoided as nasal swelling may occur. The expected course of disease, that is symptoms peak at 3 to 5 days, followed by gradual improvement with the resolution of symptoms in 2 to 3 weeks. These points should be educated to caregivers. Encourage adequate oral caloric and fluid intake. Advise caregivers to avoid exposing the patient to secondhand smoke. Admission criteria for bronchiolitis: unwell appearance, lethargy, moderate to severe signs of respiratory distress, including significantly elevated respiratory rate for age, ongoing respiratory support required, oxygen saturation greater than 90% on room air does not warrant respiratory support or supplemental oxygen, need for supplemental hydration, for example, there is inadequate oral intake or there are signs of dehydration or hypovolemia, history of apnea, consider if risk factors for severe bronchiolitis are present, supportive care at home is not feasible, for example, there is no reliable caregiver or there are barriers to follow up. Inpatient management of bronchiolitis, respiratory support, frequently monitor routine vital signs, especially oxygen saturation, adjust short-term oxygen therapy as needed. Children with bronchiolitis and oxygen saturation greater than 90% do not require supplemental oxygen. Provide regular external nasal suction. Consider scheduled nebulization with 3% hypertonic saline, sodium chloride 3%, 4 ml per dose via nebulization every 2 to 8 hours. Hypertonic saline draws water in airways through osmosis, thus causing decrease in viscosity of nasal secretions. The problem with hypertonic saline is that its nebulization may trigger bronchospasm. Discontinue treatment if nebulization causes rare coughing fits and/or worsen the patient's respiratory status. While treating bronchiolitis, avoid bronchodilators, epinephrine, corticosteroids, antibiotics, and chest physiotherapy unless there are comorbidities, for example, asthma, croup, cystic fibrosis, acute otitis media. Caloric and fluid support. Ensure patients receive the recommended daily intake for their age. Encourage normal oral feeds as tolerated, for example with breast milk, formula milk, a regular diet for age. Consider NG or IV fluids for any of the following: poor oral intake, respiratory rate consistently greater than 60 to 70 breaths per minute, worsening respiratory status during feeds, symptoms of aspiration. Prognosis of bronchiolitis: symptoms typically peak 3 to 5 days after onset and then gradually improve over 2 to 3 weeks. The onset of new symptoms or worsening of existing symptoms, for example fever, after 3 to 5 days should raise concern for complications of bronchiolitis. Complications of bronchiolitis are apnea, respiratory failure, pneumonia, dehydration, and otitis media. Vaccination. Bronchiolitis prevention includes respiratory syncytial virus vaccination of pregnant individuals in the third trimester and routine passive immunization of all infants less than 8 months of age with RSV monoclonal antibodies, palivizumab.